All right, good afternoon, everyone, and thank you so much for joining our wellness presentation today, Men's Health. We are so happy to have you all here. Please note that all of your lines will be muted until the question and answer portion of today's presentation. June is Men's Health Month, and again, we are pleased to bring to you today's presentation. Our presenter today is Dr. Papa G. Dr. Papa G is board certified by the American Board of Urology. Dr. Dimitri Papaji treats all general areas of urologic conditions. His particular areas of expertise are minimally invasive surgery, complex kidney stone disease, and benign prostatic hyperplasia. And Dr. Papaji has produced a number of publications and has received several accolades within his field. Please help me welcome Dr. Papaji.
Thank you. Thank you for the introduction. And a pleasure here to talk to you about some topic in men's health. We're try to hit some of the key areas and topics, and happy to expound on them if any questions arise. So yeah, a little bit more about me. I was born and raised in a suburb of Chicago in Naperville. Kind of Chicago born and bred. I spent 4 years in undergrad at Northwestern, and then I was at Rush downtown for close to a decade between medical school and residency. The residency, of course, being in urology, urologic surgery, and then an additional year of training and fellowship in kidney stone surgery and robotic surgery out in California. And then I came crawling back to my family and my brothers. So I'm currently out in Wheaton, Geneva area in a private practice group affiliated with Northwestern called UroPartners. And some of the topics that we were going to review today, I think these are, areas that a lot of men have questions about and are important to have some basic understanding about, kind of changes that are going on in their body over the years, and in particular because they're extremely common conditions. So BPH, also known as enlarged prostate, prostate cancer and prostate cancer screening specifically for this topic, erectile dysfunction, some questions I wanted to touch on low testosterone, and as well as sterilization or vasectomy evaluation for men who have completed their family. So first and foremost, I wanted to touch on what the prostate is, as kind of a basic anatomic discussion. So it is a walnut-sized gland that surrounds the urethra as it leaves the bladder. So as the urine is leaving, I don't know if you can see my cursor or not, but as it's leaving the bladder here and it's making its way out through the urethra and out through the tip of the penis, it runs through this kind of pink colored structure, and that's the prostate. So the very first part of the urethra runs through the prostate. The best way to view it in 3 dimensions, since this is just a 2-dimensional diagram, is that you're really peeing through a pipe. We're plumbers at the end of the day, us urologists. So you're peeing through a pipe, and as time goes by and that prostate grows, the pipe gets clogged. So that's kind of fundamentally what's going on. Its main function is really one of reproductive health. It produces fluid that helps transport sperm and make for an environment that's good for sperm during ejaculation to help with insemination. And, it starts to kind of, beyond those reproductive years, it doesn't have a kind of significant or vital purpose other than, as we do grow and get older, the prostate does start to grow with us. And that's when we can start having symptoms related to prostate enlargement. So the first topic, of course, is BPH, which is benign. So really critical to know it's a non-cancerous growth of the prostate gland. And it can cause urinary symptoms at the end of the day that unfortunately a lot of us men will experience at some point in our lives. And that's related to directly to blockage of the bladder. That can lead to flow issues as well as bladder sensitivity issues. And I think this diagram really depicts it well. So the diagram on the left is suggestive of a man who has a pretty normal sized prostate. So somebody in their 20s or 30s or early 40s. When the bladder would fill up with urine, you could hold it, for many, many hours. And even if you got an urge, your bladder would continue to expand. It was very elastic and you could hold more and more urine without really needing to rush to the bathroom. And then when you did finally make it to the bathroom, your bladder neck would open up and the urine would really fly out through the urethra and out through the tip of the penis without any blockage. What happens inevitably for all men, and every man's kind of rate of growth is different, is that this prostate grows. And it's like we had discussed, it essentially clogs the urethral pipe, it clogs the drain. And so we see several symptoms related to this. And some of them are straightforward, like, oh, my drain's clogged. Okay, I'm going to go slow. It's going to be a slower flow. It might be hard to stop the tap. It kind of dribbles a little bit. It starts and stops a little bit. Or maybe I go there and stand there for 5 minutes at the baseball game and miss the third inning because I can't really get it to get started. So that's kind of more of a blockage issue. Now, at the same time, and equally bothersome symptoms are the bladder symptoms that can develop. So because the prostate is downstream of the bladder and it's clogging the drain, the bladder muscle has to make adjustments. And what we see is, at least in the first few years, is the bladder muscle gets thicker. So, and this picture doesn't really show a thickening bladder, but the bladder muscle does get thicker, and as such, it doesn't really relax as well as it used to. It's very tense, and it becomes a little bit smaller as a result of the thickening. And what can result from that then is a bladder sensitivity issue. So the bladder loses that beautiful elasticity that it had when we were 10 or 15 years old, and instead is kind of tense and thickened, and a little bit of urine goes a long way. So we start to have more urgent symptoms, urgency and frequency in getting up at night, because quite honestly, the bladder is just is thickened and is unable to relax the way that it used to. So who can get enlarged prostate? I touched on this. It's first and foremost, it's the most common prostate problem in men over 50, more common than prostate cancer, more common than prostatitis or infection or inflammation of the prostate. And you can see it's very closely linked to age. Somebody who's maybe by age 50, I say, hey, about half of men are having some problems. And you best believe when you live to be 90, 95, if we're all that lucky, pretty much every man is going to have some of those symptoms. So risk factors for enlarged prostate is, first and foremost, age. There appears to be, like most things, a genetic predisposition, namely if it runs in the family, especially if your dad got it at a young age or is having prostate symptoms, you might be somebody who has a prostate that grows a little bit faster. And even though there isn't a direct link to the following, it does seem that men who have a higher BMI or are obese, or men who are less active, and a sedentary lifestyle, tend to have more bothersome urinary symptoms on average. So how do we diagnose BPH or enlarged prostate? Usually when we see a man in the office, a lot of it can be obtained just by talking to somebody and understanding what, their age, other risk factors, maybe other potential causes, but a good history and then a physical exam are really critical. And a lot of this is a clinical diagnosis. But additional testing, especially if we're thinking, you're not responding the way we want to, that's when additional testing can be helpful, especially if we're thinking something procedural or surgical to fix the problem. We definitely want to understand the prostate anatomy better. So sometimes we would do something like a prostate ultrasound to understand how big it is. Something that we all fear is a cystoscopy or a scope. It's a bladder scope. Small little flexible camera that goes up through the tip of the penis, through the prostate into the bladder. That's a really critical test, and thankfully only takes about 60 seconds in the office. We also will sometimes see, hey, how well is your bladder emptying? Maybe that gives us some insight into how blocked up you are. Sometimes we do little scans or ultrasounds of the bladder to understand how well it empties. And then something we call urine flow studies, which are essentially saying, hey, why don't you pee into this bucket for me and let me see how fast your bladder empties? And that can tell me how clogged you are. Well, once we make the diagnosis for BPH or enlarged prostate, who needs treatment? And we know that almost every man will develop these symptoms, and certainly not every man needs treatment. Really, only a small percentage of these men truly need treatment from a medical standpoint, and we probably put those rates at about 5% or less. So that's when we're seeing something medically dangerous or problematic for our patients. Somebody who's unable to urinate and needs catheters to be able to urinate. Somebody who's getting repeated infections of the bladder or prostate because of the prostate enlargement. And also if we're having recurring bleeding from the prostate, that could force our hand to say, even if you're not having any symptoms that are bothersome to you, as your urologist, I'm concerned that these issues are happening and coming up, and that could be medically problematic. For everybody else, the 95% of men who have enlarged prostate, it's really viewed as a quality of life condition. And that's not to belittle it. In fact, it's nice in the sense that as a urologist, unless I'm seeing something dangerous, I say, this is something that I want my patients to drive. I want them to drive the management of this. And so if you're not bothered, fantastic. I check, make sure that I'm not worried about your bladder health or your kidney health. And otherwise, then I let my patients dictate when we need to start medications or change medications or even consider procedures. So again, that patient-directed treatment for most men with BPH is important. In terms of treatment, I wanted to walk through some of those. So first and foremost would just be an understanding, and that's kind of what we're doing to some degree today. Understanding what's going on, understanding your symptoms, I think can be really helpful in terms of managing them. And then some lifestyle adjustments can be helpful. Obviously, it's difficult, I think, if we have a significant clog to just make lifestyle adjustments to fix it, but it can help. Something as simple as, changing what type of fluids we're drinking and at what time can maybe help our men who are getting up 3 or 4 times a night and maybe reduce it to 1 or 2 times. Something like obviously reducing caffeine or alcohol, after 3, 4 p.m. And even really trying to dehydrate ourselves right before bedtime, as long as there's no other medical conditions. We say, hey, do all your drinking in the morning and early afternoon, and we try to dry ourselves out before bedtime. And then, it's kind of that, then we fall into this category of watchful waiting. So we're not really treating anything, but we're kind of monitoring the symptoms and waiting until we need to do more. The other is, medications. So medications, and so, those men who have this condition probably have seen, some of these medications listed before, might be on them. Prostate relaxant, also called, one of the classic ones that's been around for 30, 40 years is called Flomax, a medication that helps relax open the prostate. I think I got a picture here. So again, it works in the urethra, kind of in the bladder neck and the urethra area where the prostate is, to relax this tissue open. So it doesn't really shrink the prostate, but it's unclogging the drain by relaxing those hitting receptors there to relax that tissue. And that can take a little bit of pressure off the bladder. It can help with urine flow. It can help a little bit with some of those bladder urgency symptoms. And then there's the prostate shrinker medications, the classic one called finasteride, which at lower doses is used for a lot of men who have hair loss issues. This medication really works to shrink the prostate. And these can be good starting points for men, especially Flomax, really used, seen as the workhorse for enlarged prostate. Of course, like anything, they do come with some side effects. Some men notice some dizziness, lightheadedness, fatigue. Some men will notice a loss of libido or sex drive, especially on the prostate shrinker, the finasteride. So again, we always want our patients to be informed about the risk benefit of starting medications. In terms of other treatment options, there are some, if we're thinking about alternatives to medications or just observing it, there are quite a few procedures. And really in the last 10 years, there's been an explosion in less invasive, sometimes office-based options. They typically last only about 10 or 15 minutes in the office, and we usually would do it under, at least in my hands, we do it under local anesthetic like you get at the dentist, and then we have somebody breathing laughing gas. And some examples of these are, again, been around 5-10 years, steam therapy, also called Rezum. That's kind of the trade name for it. And then also a form of staple therapy. So you're not really burning anything, but you're stapling open prostate tissue, and that's called the UroLift. So some people have maybe encountered this online or even on TV. I think they are advertising some of these treatments. And for the properly selected patient, based on scope evaluation and ultrasound of the prostate, these can be really nice, definitive procedures. They carry few side effects and actually can get at the root of the problem. So I always like to discuss that up front with my patients, especially those who are hesitant to be on medications long-term or having side effects on medications. And I think I had a couple of videos. I might need help queuing those up.
Yep, no problem.
Thank you. So this first one, I think we'll start it at about 2:45. This is that Rezum steam therapy. I just wanted to show the group a little animation on that.
The new first-line therapy for BPH. Resume therapy uses convective water vapor energy, or WAVE technology, to deliver highly targeted, controlled doses of the thermal energy stored in water vapor. In just seconds, this precise technology destroys unwanted enlarged prostate tissue while minimizing any effect on surrounding tissue. Resume therapy is a potential alternative to drug therapy. It preserves sexual and urinary functions, and it's clinically proven to be safe and effective. The procedure is performed right in your doctor's office or outpatient center. You do not need to be unconscious for the procedure, and Resume therapy lets you quickly return to normal activities. Talk to your doctor about Resume if you're no longer comfortable dealing with your BPH.
Thank you. And then the next animation is on that UroLift as an alternative. Just shows the the basic anatomy. It's about a minute long.
UroLift system is a new minimally invasive technology designed to relieve urinary symptoms and improve quality of life for men with an enlarged prostate caused by benign prostatic hyperplasia, or BPH. As the prostate becomes enlarged due to BPH, it presses on the urethra from the outside and causes it to become blocked. Relieving obstruction of the prostate is clinically proven to improve urinary symptoms in men with BPH. Under endoscopic guidance, the UroLift system is gently placed into the urethra to the area blocked by the enlarged prostate and moves the obstructing prostate tissue out of the way, thus opening the urethra. Through a fine 19-gauge needle, an implant is deployed that holds the prostate in this new, less obstructed shape. The UroLift system is designed to offer a new way to relieve prostatic obstruction without cutting, heating, or removal of tissue. Next, the same technique is applied to the other side of the prostate. Because the outer capsule of the prostate is typically firm, it holds the urethra open. The number of implants required depends on the size of the prostate and the degree of obstruction. Typically, 4 to 5 implants are used. Before applying the UroLift system, the urethra is blocked due to an enlarged prostate pressing on it from the outside. After applying the UroLift system, the prostate lobes are pushed aside, leaving an open urethra.
Thank you.
Okay. And you may just have to open your PowerPoint.
Open the PowerPoint again. Okay, let's see if I can get that open. There we go. So those are some of the office-based or minimally invasive options. There are some tried and true measures that are done under, more traditionally under general anesthesia at the hospital. And again, depending on the size of the prostate and the anatomy, these might be the best choices. One is a laser prostatectomy. So going in with the camera and actually using a laser fiber it's almost like a flamethrower, for lack of a better way of describing it, to vaporize tissue that's clogged in the system. So it's a different way to serve the same purpose. And then the classic, or kind of the oldest procedure, and still an excellent choice for some men, is the TURP procedure, or the Roto-Rooter. And that's kind of what this schematic is depicting. Going in with the camera, this is all blocked up prostate tissue, and essentially under direct visualization, scraping open that prostate. So suddenly you're unclogged and your flow is much, much better. I wanted to pivot, and talk now a little bit about prostate cancer. And it's the same organ, but it's a different process. So it's, in a lot of ways, it's completely unrelated to BPH, which we just reviewed, but they can both be occurring simultaneously. And sometimes they are, because both are extremely common, especially as we get older. It is the second most common diagnosed cancer in men. And in many cases, it does grow slowly and may not really impact life expectancy, especially if it's detected later in life. We can see that diagram to the right is really showing the incidence, or kind of how common prostate cancer is by age group. And you can see in our 30s and 40s, it's extremely rare, but it does start to take that upward turn in our mid-50s. And that's why, the prostate cancer, screening guidelines really kind of follow this curve. And the critical thing is, well, if a lot of cancers, if these cancers don't hurt us, or a lot of them don't, why screen for them? And that's because, of course, there are some variants of prostate cancer that are very aggressive and need to be addressed. So in terms of how we detect prostate cancer, very rarely does it cause urinary symptoms. And I'd say 99% of the time it's really silent unless it's very advanced. So screening is the kind of the critical way for us to catch this cancer early. And it's recommended certainly starting at age 55, and usually in that age group of 55 to 70, yearly screening is really encouraged. That doesn't mean if you're younger than 55 that we shouldn't or couldn't check. And if you're older than 70 and healthy, that we shouldn't check as well. It depends on risk factors and health and all those other things. So the screening tests really start with a PSA test, which is a prostate cancer screening test, prostate specific antigen. And that's sometimes done as part of your annual labs, depending on your primary doctor, or when you see a urologist, oftentimes you'll have the discussion about whether or not you should check it. So that's number one. And then the second part, at least for urologists, and not all internal medicine or family medicine doctors are doing that these days, is a prostate exam. So that's kind of depicted on the right side. So through a gloved finger, don't worry, we always wear gloves. We put a finger up the rectum, up the anus, and just barely into the rectal wall, just to feel the prostate on the other side. And that allows us to feel for any nodules or bumps that might be a little more suspicious for cancer, although certainly it's a little limited in the sense that if there's something small going on, we won't feel anything. Or if there's, let's say, a cancerous process on the other side of the prostate, closer to the abdomen over here, we obviously wouldn't be able to feel that with our exam. But when cancers develop, they most commonly develop on the back side of the prostate, and that's why the finger check for urologists is still really critical. And then something that's evolved in the last 5 to 10 years or so is using MRI of the prostate a little bit more to get a little more information before we do anything more invasive like a biopsy. But certainly, depending on the PSA and the exam and maybe an MRI, prostate biopsy is often something that's pursued for men that we're concerned about. And that's typically done in the office under local as well. And we do a series of samples of the prostate to sample the tissue and identify any cancer cells. In terms of treatment, like I alluded to, not all prostate cancers require treatment. In fact, probably the majority don't. But the biopsy is really the critical thing. So that tells us, okay, is there cancer or not? And if there is indeed cancer, how aggressive is it? And that really drives management. If it's a non-aggressive cancer, even if you're a young man, oftentimes we monitor it. But if it's aggressive, then it definitely needs some form of treatment. And in terms of management, like I said, surveillance really means we're not treating it, we're just watching it. And then there are several treatment options for prostate cancer. Really the two main arms, one is surgery, and something that I did a little extra specific training in is really robotic or laparoscopic robotic surgery to remove the prostate. That's kind of shown here. The surgeon is on this kind of new age console system. And when you're looking in, you can actually see in 3 dimensions through a laparoscope. You can see kind of 3-dimensional anatomy. And the patient is typically obviously on the table there, and there's a bedside assistant that is passing cameras and instruments. And then the robotic surgeon is off to the side and is able to manipulate the robotic arms to do very careful dissections, sometimes a couple of cell layers deep. And so it takes out any hand tremor and allows us to be very precise with kind of what tissue we cut and what tissue we leave behind. And then an alternative to prostate removal is radiation therapy to the prostate. That can also be a very effective way to cure the cancer. And sometimes there's some hormone therapy that's required as well, depending on if the cancer is very aggressive. So moving on from the prostate a little bit, I wanted to talk about ED. Erections, despite what some people think, are very complex. It involves an interface between several different systems, the blood supply or vascular system, nerves, hormones, and then certainly psychological. There's a psychological impact as well that can make erections possible or impossible depending on what's going on in our mood or in our emotional life. Similar to some of these other problems, again, and that's why these are all men's health discussions, is that they, at a young age, they're not as common. although we see them. And then increasing decade by decade, they become extremely common where, anyone over the age of 70, I think it's very rare that they're getting erections without some form of help. Risk factors for ED, other than age, would be, smoking history, being overweight, heart disease, diabetes. So really anything that's unhealthy for your cardiovascular system is also equally unhealthy for your erections because, erections, in order to get an erection, you need strong or good blood vessels that aren't clogged and aren't inflamed related to high blood pressure, diabetes, and everything else to actually get the blood into the erectile tissue and also to keep it there. There are some medications as well, and especially for younger men, if we're having severe ED and we're on some form of antidepressants or some blood pressure medications, that can sometimes also have an impact. Although I'd say the majority of the time it's other factors. In terms of treatment for ED, lifestyle adjustments are really critical to sometimes reverse some of the ED, but more than anything, it's really to maintain erections with where they're at. So try to maintain healthy erections. Even with excellent lifestyle adjustments, we might not completely restore erections, but the idea is we prevent them from degenerating more. So heart healthy diet, exercise. For those who smoke, I always strongly encourage quitting smoking. And then if necessary, with input from our primary doctors, maybe some medication adjustments. Beyond lifestyle adjustments for ED, we, of course, all of us have heard of medication options. They are viewed as first-line therapy. So somebody who's saying, okay, I'm not smoking, I'm not obese, I'm doing great with my diet. The first thing we would typically prescribe is the generic forms now of Cialis or Viagra. And the beautiful thing about that, I guess, now is that they are much, much, much cheaper. So a low-dose generic Cialis should be able to get it well less than $1 a pill. And even the higher doses, maybe a couple of dollars, whereas before it used to be $20, $30, $40 a pill. Cialis and Viagra are the most common, and they're the two that are generic now. So it's very rare that I would stray away from the generic forms of these. Overall, effective and safe and inexpensive now. So that's why we'll usually start with those. In terms of, second line therapies. So if, let's say, the medications aren't working for us, whether because they're ineffective or side effects, there's a couple of second line therapies. One is injection therapy, and that's why I threw up a gruesome diagram here. Vacuum and a vacuum erection device. So injection therapy is really the idea of administering medication directly into the erectile tissue of the penis. And for men who have, especially for men who have nerve damage down there, this can be a really nice way to bypass the nerves. So for someone who've had their prostate removed because of cancer and they're having difficulty with erections, this is an excellent option. But it's also upping the ante a little bit from just taking the pills. It's putting the medicine exactly where it needs to be. And you have to do an injection about 20 minutes before sexual activity every time, but it can be very effective, especially if the pills aren't working. And then, there's the vacuum erection device, or VED, which is essentially that pump that you place over the penis, and you create a vacuum, and it pulls blood into the penis, and usually a ring, some form of constriction ring is required at the base of the penis to keep the blood in there. That can be a good choice for men who have a needle phobia, medications aren't working, or if they're very sick and we don't want to mix medications with some of their heart issues or something else. The vacuum pump can be a nice alternative. Obviously, the least, I'd say, spontaneous, the most cumbersome perhaps, but if we have an understanding partner, it can be a good choice. And then third line therapies, and rare that we get there, but there are surgical options for men who have failed medications and injections, potentially surgery to actually put a prosthetic implant into the penis. And so, that the satisfaction rates for this procedure are very high, but we always try to reserve that for the end of the line. Anyone who has surgery for this, once they have a surgical prosthetic put in, they won't be able to get an erection on their own again. So it is kind of the end of the line. And one thing I wanted to mention that's relatively experimental is that acoustic wave therapy that, I think everyone's hearing on the radio now. And sometimes when I'm driving to work, I hear it and I think I need it. But it is really it's essentially delivering sound waves to erection to the penis. To the idea being to try to break up some calcium deposits in there or really invigorate that tissue by inflaming it to maybe increase blood flow. There seems to be something there, but in the urologic community, we're very evidence-based and study-based. And we tend to see, it's certainly in terms of its recommendation, it's really viewed still as experimental. Maybe for men with mild and maybe mild to moderate ED, it might move the needle a little bit in terms of helping with erections. But certainly men who have severe ED or are failing pills, it's very unlikely to make a big difference other than in your pocketbook, because there are a lot of these health clinics that are popping up. They somehow got their hands on one of these, this wave technology. And so anyone who walks through the door is going to, hey, give us a couple $1,000s and we'll shock your penis. And, oftentimes it doesn't do enough. So I'm always hesitant to encourage that unless I feel like somebody has pretty mild ED and it might be worth a shot. But, more to come on that. I think in the next few years, hopefully we'll have more data and more understanding of who might benefit from that. One thing, kind of dovetailing into kind of another similar topic would be this, low testosterone. In some cases also called hypogonadism, but basically low testosterone production. It can be related to several different factors. Sometimes testicular failure, the testicles just get worn out over time, whether it be related to age, or sometimes men who have had other health conditions on chronic steroids, or men who have done exogenous testosterone for muscle building, their testicles have probably atrophied and failed a little bit and sometimes aren't producing the level that's required. And sometimes you can also have other issues going on in your body, other hormonal imbalances that can cause lower testosterone in the bloodstream. It's important to know that this is also a natural process, and like everything else I've discussed today, it tends to decline. Testosterone production is a natural change, and it tends to decline with age. Similar to the shockwave therapy for the ED, this has gotten a ton of media attention. We call that a media blitz here in recent years, where it seems like everybody who's over 35 probably would qualify for testosterone replacement. And certainly it's an important thing to evaluate for and think about depending on symptoms, but treatments are not benign. They're not without long-term potential effects. So we always want to be very careful about, who we advise to go on testosterone replacement. In terms of how we diagnose, and this is what's tricky about it. Diagnosis can be hard to peg down. It's not like when you do a prostate biopsy and you find cancer and you say, yeah, you have cancer. Or we do a CT scan and we say, oh yeah, you have a kidney stone here. This is how we treat it. Low testosterone symptoms are very vague and nonspecific. And pretty much every symptom related to low T could be explained by literally hundreds of other conditions, like, hey, I'm gaining a little bit of weight, or my energy is lower, my sex drive is lower. A lot of those things have many, many potential causes. But at the very least, we want symptoms that are suggestive of low T. And I'd say probably the most common one that is linked to this is a man who's like, hey, I've kind of lost my interest in sexual activity. That's a little bit atypical, especially for men who are a little on the younger side. And so that one kind of cues me in a little bit more than some of the others. Like, hey, I'm having a hard time concentrating, or I'm not, I'm getting a little bit thicker and I'm having a hard time losing weight. But those are some other potential non-specific symptoms. And then the other thing, so we need symptoms, but we also need testosterone levels that are viewed as low. And at least a couple of those tests with some additional hormonal tests to confirm, okay, your testosterone is low and your symptoms are suggestive of low T, maybe we should try treating it. And that's the last critical piece for me, is that when you put your testosterone back into a normal level, do you feel better? And there are plenty of guys that go on it, and if they don't after 3 to 6 months, I say, well, I don't want to just chase the number and say, let's make your testosterone what it was when you were 30. Although that sounds great, it may or may not change symptoms, quite honestly. And so in that case, we'd say, well, if you're not getting better, then I don't necessarily want to keep you on this therapy. In terms of treatment for low testosterone, per usual, there's oftentimes something we can do from a lifestyle side of things. We know weight loss is critical. For men with a lot of fatty tissue or obesity, testosterone gets converted to estrogen in the fat tissue. And so one really important thing is, well, if we can get down to fighting weight and get down to a kind of a healthier weight for men who are overweight, that can also help us preserve kind of the natural testosterone that we have. Exercise can really invigorate testosterone production, and increasing protein potentially in terms of dietary measure, dietary protein can be helpful. Alcohol seems to be linked to lower testosterone production, at least in higher quantities. And in terms of replacing testosterone, if we get to the point where we say, yeah, your T is low and you're doing everything you can from a lifestyle standpoint, there are medications and there are various forms of administering them, all with the idea of increasing the testosterone in the blood. So there's creams or lotions that can be applied usually to your shoulders or to your back on a daily basis. And then there's also injections. Thankfully, this one doesn't go into the penis, but usually into the thigh, where you'll inject testosterone maybe once a week to bring it up to a normal level. And then there can even be some implants similar to what women get for birth control, for contraception. We can actually implant testosterone pellets that slowly release testosterone over a period of 6 to 9 months. And then the critical thing when we're on testosterone replacement is monitoring. So blood counts need to be monitored. Your PSA or prostate cancer screening test needs to be monitored. Testosterone levels should be monitored, of course, and monitoring for symptom improvement. In terms of treatment effects, we say, okay, for men who really need it, I think it can be a fantastic option. Can improve strength, lower body fat, improve bone density, as testosterone does help preserve bone health, and can increase libido for men who are suffering from that. And then in terms of downsides, some men will notice some acne. Blood clot formation is possible. So blood clots in the legs or in the lungs. It does affect fertility. So it's almost, not to say it's the best form of contraception, but for men who are trying to have a family and they're on testosterone, it can really impact healthy sperm production. It can, for some men, worsen urinary symptoms. So going back to the beginning of our topic, BPH or enlarged prostate, the prostate can become inflamed and irritable when we're on testosterone. And it can affect prostate cancer growth. So for men who have it doesn't cause cancer, but for men who have prostate cancer that's maybe not been detected yet or have a lower grade cancer, testosterone kind of feeds the cancer. So it can cause prostate cancer to accelerate. So certainly that's all part of the way that we screen. We would always monitor the prostate cancer screening test while you're on treatment to ensure that there's no major changes there. And then one last thing, especially for some of my younger men in the audience, is just talking a little bit about sterilization and specifically vasectomy. So vasectomy, for those who haven't been through it, it's really viewed as a permanent form of sterilization. Although it is technically reversible, it is a little bit more involved in terms of reversing it than doing it, and usually involves microscopes and several hours of surgery. Vasectomy, there are some, suggestions out there and that I can debunk some myths. It does not affect testosterone production, does not affect sex drive, does not affect erection quality. But certainly, like anything, there are some side effects or complications that can occur with any procedure, including vasectomy, and they tend to be rare and mild, thankfully, with this procedure. Typically, an infection of the skin, rarely an infection of the testicle, a skin sensitivity, over the area of the incision, and sometimes maybe a nerve sensitivity in that area. Rarely it can be kind of persistent and really bothersome. That requires additional testing and treatment, or like a nerve release. And you can get, especially right after the procedure, severe bruising that might take 6 to 8 weeks to go away instead of 1 to 2 weeks. That's called a hematoma, and that's something that we always counsel. That's why we always say, hey, take it easy for a week, really rest, watch a bunch of March Madness or the NBA playoffs, whatever's on there that time of year, and ice that area with some peas, and then cook the peas later in the week. And then in terms of success rates, they're very, very high, although nothing is perfect. And everybody seems to know someone who knows somebody who had a kid after vasectomy. Pregnancy rates are well below that we see with other forms of birth control, like a condom or birth control pills. But I also know it can be a life-changing event. And so, for men who have had a successful vasectomy, we're looking at pregnancy at about 1 in 4,000. In terms of the procedure itself, the procedure is office-based, tends to be office-based for the vast majority of men. Even though you're awake, we will, at least in our practice, we will offer a relaxant medication, maybe like an Ativan to take 2 hours before the procedure. And then we also give you a nice injection to numb the nerves around the testicle. And takes approximately 30 minutes in the office, about 15 minutes per side. We are nowadays doing these through pretty small incisions. I tend to use the no scalpel technique, so I don't really use a knife blade on the scrotum, but we do make a little puncture in the skin and bring the vas up and then cut it, separate it. And then typically all you'll see on the outside is a couple of dissolvable stitches. Why do we have a failure? Well, we cut this and burn it and separate it and tie it off, but it has something probably to do with some delayed healing or inflammation that can bring these tubes back together, and somehow, some way, life finds a way sometimes. Recovery specifically for this procedure, like I mentioned, resting pretty aggressively for 2 to 3 days, then you're usually back to full activity within a week. And with that, I'm happy to answer any questions that have come up.
All right, thank you so much, Dr. Papaji. That was a lot of information, a lot of great information. Yes, now's the time for our Q&A portion of today's seminar. If you have dialed in, *6 to unmute your lines. Otherwise, we do encourage you to type any questions that you have in the chat feature. We do have a comment. Great presentation.
Oh, thank you. Thank you. Yeah, pleasure talking about this stuff. And I know it's really, things that all us men deal with at some point in our lives. If it's not all of them, it's at least one of them, if we play the odds.
I have a question. Dr. Papaji, I didn't hear you talk about any type of like natural supplements that men can take to help with their prostate. Correct me if I'm wrong. Is it saw palmetto is a natural supplement that men can take? Can you elaborate on that a little bit?
Yeah, absolutely. Yeah, saw palmetto is, there are a lot of supplements out there, and thanks for bringing that up. Kind of similar to the shockwave of the penis or the low testosterone thing. I mean, there's a lot of stuff out there, and so it can be very confusing if you were to Google, hey, enlarged prostate, what supplement should I take? There's about 1 million. Most of them have not, of course, been studied adequately for us to be able to prove symptom improvement and also disprove side effects or issues related to it. But that being said, I don't look down on anyone who wants to try supplements whatsoever. I just want to make sure it's not something that's harmful. Specific to, the enlarged prostate question, one supplement that has been studied quite a bit and appears to have fairly good efficacy is saw palmetto. So that's, that is a natural supplement that's found. And now in a lot of these things like super beta prostate and stuff, they do have that as a working element. For men who want to try supplement as opposed to a prescription, I always say try to find one that has pretty much, almost exclusively saw palmetto in it. There's some other things, that are thrown in that are fillers that we haven't really studied. But saw palmetto does seem to have similar efficacy to Flomax in a lot of ways. And for some men, it just works for them better, or they just feel more comfortable not being on a prescription.
All right, thank you so much for that clarification.
Absolutely. I need to find one of these cones to put on somebody after vasectomy. It'd be pretty funny. I should start administering those in the office. They might not want to come back though.
We do have a question in the chat. Would you recommend seeing a urologist periodically after a certain age, or is it the general practitioner usually good enough for most issues?
Yeah, I mean, I think it's kind of, patient and practitioner dependent. We do have some men, and I always try to tailor, follow up with them, based on their preference and how well they're, how closely they're following up with their primary. Obviously, a lot of primaries do a great job of dealing with kind of especially introductory issues, related to BPH and maybe even starting a patient on Flomax or saw Palmetto, and certainly doing some prostate cancer screening with the PSA tests. If some of these issues are becoming, and maybe even doing some Viagra, if some of these issues are becoming a little bit more complex or more moderate in severity, then oftentimes we get somebody into the office for an initial meeting. And then from there, kind of depends on how well controlled we are and what we're monitoring. It's not uncommon that after the age of 55 or 60, because one or several of these issues are pretty active, I'm seeing them at least once a year. But it also depends on the person. Some patients are like, hey, my primary does a great job, and I'd prefer just to work through them and come back and see you as needed. I think that's great. At the same time, if they say, hey, doc, I just prefer to see you once a year to check my prostate and, to talk a little bit about my PSA, which has been a little bit up and down over the years. I love being there for them in that capacity too. So it's not uncommon to see a urologist regularly after the age of 50 or 55, but not always necessary.
All right, thank you for that. There is another question. How reliable are recommended tests for pancreatic cancer?
Pancreatic cancer, so that's a little bit outside my scope. That's a little bit more with the GI system, so that's probably not something that I can comment on quite so well. I do know that, there are some blood tests that can be helpful. Similar to PSA, though, they're not diagnostic oftentimes, so they're not perfect, but they can be a starting point, especially if your primary doctor has concerns. Some blood work can be helpful. And then sometimes after that, imaging, like a lot we're doing lately, imaging can be really helpful at evaluating the pancreas more. But beyond that, unfortunately, I did a little bit of pancreas when I was an intern, but that was about a decade ago. So I'm probably not equipped to answer that question anymore.
Again, if you have any questions, go ahead and type them into the chat feature. You can do it privately to Dr. Papaji, to myself, or you can unmute yourselves and ask them directly.
And hopefully this hopefully gave you, at least a, basic understanding of kind of what you can expect in terms of changes, body changes that we're all experiencing, and make you feel like you're not alone, certainly, because like I said, the vast majority of men have these symptoms.
Okay, I think that is it for all the questions. Mia, am I overlooking any?
Oh, yes, I had a question.
Yes.
Doctor, could you tell us what is best to look for, or the best way to do a self-exam for testicular cancer, or discuss testicular cancer and the risks to men?
Yeah, absolutely. So yeah, not something that we touched on today, but thanks for bringing that up. Testicular cancer, it tends to be, and not always, but a young man's disease. So a lot of men in their, adolescence, puberty, in early 20s, that tends to be the time when testicular cancer, although rare, can start to pop up. And it's way, way less common than bladder cancer or prostate cancer. Self-exams, there are, I do encourage it, although I would say that, sometimes, obviously it can lead to some anxiety for somebody who's feeling something they're not sure what they're feeling, or they're not sure if it's normal or not. But typically just, assessing the testicle every once in a while, every few months, checking it in the shower for smoothness and making sure there's no asymmetry there. Probably the biggest thing is you feel if testicular cancer pops up, it really feels almost like a marble that you feel on the testicle that wasn't there before. And it tends to be very, very firm. It doesn't tend to be tender or painful. So a lot of men with testicular cancer have a painless growth. The best way obviously, if you feel something like that, the vast majority of the time, thankfully, if you were examined by a urologist or somebody who does a lot of exams, will generally find something benign, like a benign cyst or growth, that's actually on the epididymis, which is a a little structure on the backside of the testicle. So there's a lot of extra tissue behind the testicle, and a lot of cysts can develop back there. On the meat of the testicle, if there's a growth, then that usually needs to be evaluated more. And sometimes it's difficult for a patient and sometimes even a urologist to tell, hey, is this a cyst on the epididymis behind the testicle, or is it a growth on the testicle? And sometimes the next step for us is to do an ultrasound of the scrotum and the testicles to better understand that. Thankfully, again, it's not something that's super common. We do tend to see it more, again, runs in the family, runs in men who have probably the biggest risk factor is an undescended testicle. So somebody who had a testicle that never fully descended into the scrotum, or maybe it was surgically pulled down. And if it was pulled down before a certain age, before puberty, then the risk of cancer is lower. But if it was high riding and we had it pulled down when we were like 20, we do have an increased risk of testicular cancer in that testicle. So that's probably the biggest risk factor that we know of for this disease.
Thank you.
Absolutely.
I do have one question that came in as well. It says, if you've had kidney stones in the distant past, how likely are they to come back?
Good question. That's it's kidney stones are certainly a topic, or a disease process that I'm particularly interested in. And sorry we didn't have time to dive into that specifically today, although that affects both men and women, certainly. It is, if you've had a kidney stone before, you're much more likely to have another one. But, it's kind of a cop-out answer. When we look at the data, if you do nothing different, we'd say at 5 years, you're 50% likely to have another kidney stone attack. So 5 years, 50%. If you see a urologist and sometimes start either lifestyle or medication adjustments or supplements to make for a better environment, we can really drop that rate down. Maybe not drop it to zero, but we can really slow the progression of kidney stones if we start you on something that we see as problematic in the urine.
Okay, we have an additional question. Is minor weight gain a significant problem for urinary health?
It's not. I mean, all of us have ebbs and flows. I think in terms of our exercise routine and our weight gain and weight loss. A little bit of weight gain is not uncommon. I think we do tend to see that if we're significantly overweight and we're continuing to gain weight or we're struggling, it can affect prostate health either directly or indirectly. And again, it's linked to diabetes, right? And diabetes can then affect bladder and prostate and urination and all of those things. So a little bit of weight shifting is okay, but we do tend to see, if we were to compare somebody who's normal weight versus overweight, the overweight man tends to have a little bit more problem.
Okay. One last question. How do you know if you have a problem with your kidneys?
The best way is through blood work, and that's really usually if you're doing your annual screening, your kidneys are being checked. So a kidney function panel is part of it's called a basic metabolic panel. So it's one of the very commonly performed blood tests that are done. That's the best way for us to get a sense of the kidney function. Sometimes urine testing can help. If when we do a urine test, we see a lot of protein in the urine or a lot of sugar in the urine, and a patient doesn't have a diagnosis of, let's say, diabetes or something, we definitely bring that to their attention. But kidney function can be very, very easily assessed on blood work.
Okay, wonderful. And okay, we'll go ahead and wrap up with this one last question. How much water should an individual be drinking daily?
How much water? So for us urologists, I think we tend to lean on the hydrated side. In a vacuum, namely you don't have any other major medical problems, I usually encourage somewhere between 60, 80 ounces of fluid a day, most of that being water, at least half of that. And that's really good to help keep you hydrated and reduce kidney stone formation. Yeah, for my kidney stone patients, I'm usually pushing 80 to 100 ounces a day. But certainly if we have heart issues or other medical conditions, it might, we might be limited in terms of how much we can take in. So it's important to also take those things into account.
Okay, wonderful. Thank you so much, Dr. Papa G, for all of this information. Thank you for taking time to educate us today. And thank everyone on the platform too. Thank you for participating in today's presentation. Please remember that Cigna EAP is available to assist you with many of your needs. Please visit mycigna.com or you can call 888-371-1125. We also encourage you to visit our wellness website for upcoming seminars and events, tools, resources, things of that nature. You can go ahead and visit transitchicago.com/wellness. And with that, we'll go ahead and bid adieu to everyone. Again, thank you. Everyone stay safe and be well.
Thank you very much for the privilege. Take care.
Thank you.
Bye-bye.